So let's just dive in. And good morning, everyone. Get your coffee. So I have no financial relationships to disclose. If anyone has any that you'd be interested in me doing, I'd be happy to have a conversation, but I don't have any at this point. So what we could talk about, we're going to talk about really what is obesity, and we're going to talk about the evolution of bariatric surgery and how it's evolved over the years. Every time I get to talk to a group of primary care docs and internal medicine people, I like to really hit the stigma of bariatric surgery in the face and clean up any potential bias we may have because of the things that kind of people still have in their head lingering from the history, really, of bariatric surgery, and really flush it out and say, what is bariatric surgery today in 2022? Because it's a lot different than it was in the 90s. We will talk about the common procedures performed today and then outcomes, talk a little bit about diabetes. We have Dr. Stroh coming after me to talk about diabetes, and I will leave all that high-level diabetes talk to him, but we'll talk about a little bit how it relates to really bariatric surgery and really what the primary doc should know. And then we know how important the insurance is and the pathway, and everyone might have ideas about that. So I'll try to answer all that and flush out how do you get patients into surgery. So a little bit about me. I don't want to get into this. Sorry, this was a lecture used somewhere else where they told me to give a little bio, but kind of been everywhere like so many people in this room where you travel kind of all over the country. Ended up here. I am part of the Franciscan Center for Weight Management with my two partners there, Dr. Anwar and Houseworth. We do one of the highest volume, we are the highest volume robotic bariatric center in the United States. In the state of Washington, we do really more surgeries than most other centers. We did join with Virginia Mason now. So we keep getting bigger. We have now 3 locations. We are combined with our wonderful colleagues up in Seattle with Dr. Chang, Dr. Deal, and Dr. Malapeti. And we started another ancillary site up in the peninsula. So we kind of have 3 sites now. We're kind of just growing. But let's talk about obesity. About 40% of Americans are obese. 7.7 are morbidly obese. Again, this is not just located here. This is worldwide. The obesity rate's tripled since the 70s. And this is a slide, and some of these are going to be slides we use in our seminar for patients. And what I impress upon our patients is, yes, we could be making better decisions with our diet and exercise that lead to us gaining weight, right? But it is not all your fault, right? The cards are stacked against us. Otherwise, 40% of the population wouldn't be obese, right? Genetics and other health reasons. We take medications and steroids, which make it very difficult for patients to lose weight. Community culture and the environment, these things are just embedded in our society, right? Come over for the birthday. Okay, what's the first question you ask, right? Well, what do we have and what should I bring, right? It's not evil, but it's never anything super healthy. It's never anything in the right portion. So there's lots of things, life-changing events, people have stressful things happen in life, or good things. You have a baby, very difficult to get back in the routine and working out, right? So everyone kind of gains weight. So this is not, we have to look at obesity as not this person's making bad decisions and they're being lazy and they're not working out. It really is a societal problem with lots of things going against each individual person in order to stay healthy and lose weight. In the state of Washington, we're pretty good. We're ranked number 39 out of 50 in terms of obesity rates. But the point of this slide is to see that we know obesity affects everybody. It doesn't matter what your race is, your age, or your gender. Everyone is affected very much by the obesity pandemic. And how does it affect our patients? Well, as we know, you're just unable to enjoy life like before before you're overweight. Everyone talks about up here, we're hiking, we're camping, we're going on trips. I had a patient who, when I first met her, came in on a wheelchair, and we did the surgery. She did great. Next time I saw her is at I think the 3-month visit. She came in walking with a walker. I said, "Oh my God, this is amazing! Look, you're walking now. You're out of that wheelchair. I told you we'd be out of that wheelchair." Well, she's like, "Yeah, that's pretty cool, but now I can get in my car and buckle my seatbelt." And I just kind of hammered home that point, like, man, being overweight affects people every second of every day. I would have probably picked walking, but the fact that it just really hammers home our patients are struggling with this lifestyle problem with everything that happens from the moment they wake up to the moment they go to bed. But of course, we know that obesity is related to significant amount of health-related problems, right? More and more we are recognizing the sleep apnea, the breathing machines at night, and you guys deal with this all the time, of course, the metabolic syndrome, diabetes, cholesterol, and blood pressure. One thing that not a lot of our patients recognize either is the incidence of cancer rates go up significantly with obesity. You know, the second most common predisposing factor for breast cancer, the first being female, okay? The second one is not genetics, it's not family history, it's not benign biopsies, it's obesity, right? Obesity is the highest risk factor to get breast cancer in this country, and you know, these things aren't quite recognized. So we know if you lose the weight, you will lose the risk for getting these things if you don't already have them, or you can reverse the process. So what do we as doctors do about this? We know obesity is a major deal. So many of our patients are struggling through it. Well, we do recommend diet and exercise, right? How effective is diet and exercise, guys? We know that it just unfortunately doesn't work. If there was a great plan, I'd be prescribing that for everyone, and I would do gallbladders the rest of my life, okay? No problem. But we know that if you give people a recommendation of diet and exercise, you're expected to lose less than 5% of your excess body weight in the long term, and usually they gain weight, right? So we just know that isn't effective to help out all these problems and medical issues and lifestyle problems they go through. So we talk about medical weight loss, all right? And there's not enough time in the week to talk about all the different medications, but we're gonna talk about some of them real quick and just kind of a brief overview. You guys are the ones prescribing these. Total disclaimer, we have a medical weight loss component to our program. I give it to the experts, you guys, to manage these medications while they have the bonehead surgeons just doing the surgery stuff. But here's a list. They're always evolving and changing. However, you know, I look at this slide, and I was looking up these papers, and, you know, when I was kind of preparing for this and reading through these, and, you know, the follow-up in these is many times 12 weeks, 16 weeks, 24 weeks. The one study, the Garvey, that's the Conquer, and now there's a sequel to it. That one at least went 2 years. And we're talking about with medication, and that's the one on the far left there, that's the phentermine and topiramate combo, which has been, in all these studies I was kind of looking through, the most effective. You know, we're talking about 20 pounds, you know, and these are patients who, and that's just at 2 years, and that's the best of all of them. And these are people who've they weighed, the average for all these were about 225 pounds, and they get down to 200 pounds. You know, I wasn't able to dig in all those studies and come up with everything, but I don't think the resolution of diabetes and blood pressure is that significant when you're with that little bit. Now, these are effective. I think they're most effective, and you could talk to Dr. Eager, he's my colleague in St. Francis, who's the master at these things, who says it's best, these medications are best for people who have had surgery, they lost a bunch of weight, and then 10 years down the road, they start to regain weight. Those are the great candidates who may do better with these medications. To give someone who's overweight these meds, expect them to lose 100 pounds, isn't realistic. And this is what the data show. So again, what do? We recommend diet and exercise. We try medication. There is a role, but sorry, in my world, those numbers don't, you know, speak much to me. So we then start talking about surgery, okay? And here's why I want to talk to you guys. All that for this, okay? Why do I still hear this? Oh, you do the band surgery, right? Or you hear things like, my cousin's friend's aunt had that and she gained all her weight back, okay? Or someone I work with did horribly after getting that bariatric surgery, right? I mean, these are things we still linger in society. So obesity rates, I'm gonna go through a little history. I think it's a little fun to think about kind of how it's evolved to kind of flush out where these concepts came from, why people still think of obesity. Surgery is kind of the stigma attached to it with bad outcomes. And it started back in the 50s when there's a paper that says, we have a horrible epidemic of obesity in the 1950s, 10% of our population is obese. Little did they know. Hello, high fructose corn syrup. And this is how they were looking when they were operating on people, okay? So this is when they started doing surgeries, okay? And real quick, you know, the first surgery was in Sweden, of all places, where they just took out a whole bunch of small bowel on this 32-year-old woman, okay? Outcome wasn't really determined. They just took out a whole bunch of small bowel, put it together again. You're gonna lose weight. You know, it evolved over into the 1960s where I'm having a hard time to even understand what some of those connections would be. I would need a chart and really sit down and think about to draw out what, you know, diversion of proximal small bowel into the colon. I mean, really dramatic, crazy things. They saw a 10% mortality rate, horrible floral imbalances, severe malnourishment. And it took them 30,000 procedures, at least in the 60s, to realize this is probably not a good idea when 10% of people are dying, right? And Dr. Mason, he did the first ever gastric bypass, credited as one of the godfathers of bariatric surgery. And we showed it's much safer than the jejunal ileal bypass. And you know what? God, 83% of our patients don't have diabetes anymore. So we're kind of onto something, but we're still in the 60s. Remember that picture of the surgeon? Also things were evolving, the vertical banded gastroplasty, and then here's where our friend the band came in the 80s, and then they started doing it laparoscopically in the early 90s. But really during this time, the early stages of weight loss surgery, what did they learn? Well, they learned a lot about malnourishment, anastomotic dehiscence, bleeding reoperations, and weight regain, and all these things, right? So here's kind of where we learned a lot during during that time, and I don't want to minimize all those people who ended up with bad outcomes in those days, but that's just the evolution of how surgery evolves. Those are not good things. There was really, this was a great, in 1990s, right? Even in the early 90s, 10% complication rate with a postoperative length of stay of 12 days, right? And that was like, look how good we are at surgery paper. That would not be acceptable today, right? And I don't want to talk about revision surgery, right, in the 80s, right? 20% of my practice today is doing revisions of some of those procedures that we listed. Here we're talking about, although 95% survived, 28% of them were incapacitated, right? And again, I don't want to minimize or make fun of these bad outcomes, but this is where the experience, I think, where this stigma of bariatric surgery was born, right? How has that changed? Well, the ASMBS, the American Society of Metabolic and Bariatric Surgery, is a national credentialing agency, which then they've learned we have to probably regionalize and specialize this type of care. Joe out there in Kennewick, Washington, kidding, shouldn't be doing a gastric bypass once a year, right? Those people don't do well. We should probably have high volume centers that they do a lot of these things, right, to make it safer. Today, this is what it looks like. Every patient gets plugged into a national database to make sure that the outcomes are up to snuff. People have excellent long-term outcomes without any complications. So these are just a snapshot of the board that all of our patients go at. And then what else happened, right? The early 90s, the advent of minimally invasive surgery. Gone are the days of the big up and down incision to do a gastric bypass on a high-risk patient. So obviously, as minimally invasive surgery has evolved, so has the positive outcomes with it. And this is just a quick snapshot of this, the CHA database. If you're familiar, they combine all of these hospitals together. And they look at laparoscopic versus open. Total disclaimer here, in pure transparency, these open surgeries are not for weight loss. Most of those were cancer procedures once I did more digging. But the idea is there. You can see a massive improvement from readmission rates, mortality, ICU rates from 25% down to 2%. Right, a little dirty because it is different indications and the patients are different, but gives the idea. Well, great, laparoscopic surgery we saw is awesome, right? Here's your open surgery, right? We know it's a dial phone. It works. You can call people, right? Remember those days? Anyone? Well, here comes laparoscopic surgery. You can walk around. You can talk. So everyone's asking, why do we need robotics? Well, guys, why do we need this thing, right? You could be walking around with your old phone, flip phone, and call your friends and everything, but that's not the standard that we live today, right? This is a pretty good analogy. I stole it from someone from 5 years ago from their lecture that I saw, but I think it's a very good analogy. Why do we like robotic surgery, and how does that change our patients' experience and safety and outcomes? Well, guys, better technology equals better surgery, right? 3D vision, HD vision, the instruments are articulated, much different than that straight stick stand by the patient, particularly with our patients where you have very difficult ergonomics when you're doing these procedures. If you can recall back to your med school days when you have a very obese patient, you're trying to manipulate the tissue, and that all gets really minimized when you have a very forceful and precise instrument like a robot that you are controlling. And you can see when you're looking at the bypass with laparoscopic, that top line on the bottom one, I don't think this thing points very well. The top line on the bottom chart there to the top one, you can see the improvement in length of stay and the improvement of mortality rate and SSI. All these things improve our patient's outcome to make bariatric surgery even safer when we're using these technologies, and we are not renegades out here doing robotic surgery. Every time you go to a convention, it continues to go up and up and up. The utilization of robots in all surgery and bariatric surgery, we just happen to kind of be some of the first ones, doing it. We have a high volume center, so we kind of get, these, accolades kind of happen accidentally. But here's some things we were trying to convince administration to get us more robot. But you can see the decrease in hospital stay, and this is comparing to laparoscopic surgery. So just profound implications as the technology gets better. This is not the 1990s. So bariatric surgery is safe. The mortality rate is about 0.1%. You can see the reoperation, and these are in the first 30 days. Reoperation rate is 1.4%. Readmission significantly better, and the 30-day intervention is down to 1.7%. Excellent paper here if you want to kind of get a good review on bariatric surgery. If you pull this up, this progress in cardiovascular disease. It's a few years old now, 2018, but excellent kind of review. And here you can see the comparative mortality rate. Again, doing a gastric bypass these days has the same mortality rate as doing a knee replacement, or even less than getting your appendix removed, all right? So bariatric surgery with these complex patients is becoming more and more safe because of the advantages of the centralized care technology and really standing on the shoulders of those giants that went through all the harsh days back in the day that we now get the benefit from everything they've learned. The overall complication rate is 3.4%, similar to a hysterectomy. No one's going around saying don't send your patient to get hysterectomy, but really the complication rate is the same as getting a gastric bypass. So real quick, what do you guys need to know? I'm not going to go too much into these, but it's important to know the basic differences between the sleeve gastrectomy, the gastric bypass, and then you might be seeing this more and more from your patients coming in asking about the single anastomosis duodenal switch. We'll mention that briefly too. The sleeve gastrectomy, again, I hate the name. People hear the word sleeve gastrectomy and they think, oh, you're putting in a sleeve, right? Here's a mesh. And man, every time I get a patient, they say, oh, they put a sleeve in me. I just want to run away. No, we're creating a sleeve from your stomach, right? So we are, plug in the robot. We have these nice little ports, and then we take stapler and then create a skinny part of that on the lesser curve of your stomach, a little sleeve, and we remove that large piece of your stomach, right? So again, no more gadgets, all right? We don't do bands. Notice we don't do bands anymore. We take them out is what we do with the band. But this works for weight loss because two things. One, you can't eat as much, right? So you have a decreased capacity, but also we remove that fundus of the stomach, which has the cells which produce the ghrelin hormone and other hormonal changes that drive your hunger and satiety, right? So I tell my patients, you can't eat as much, but you don't care. You don't walk around starving, right? The potential complications for this, a leak rate now in the year 2022 is 0.1%. So 1 in 1,000 people could get a potential leak. In the early days, 2010, of doing sleeves, that was like the big dreaded thing. Even if they get a leak, which I, knock on wood, haven't seen one, except for someone from Mexico came up with a leak that we took care of. Especially with our colleagues at Virginia Mason, who are kind of world leaders in endoscopic treatment, they can do endoscopic treatments for leaks now. So even if you get these horrible complications that we talk about, boy, are we better at dealing with them, right? People don't need to be in the ICU with a big open abdomen and stuff like when I was training. They're much better. We're better at recognizing these issues and treating them. Here's the bypass, the old stalwart, really, been around, like we said, since the 60s. And the experience with this is just grown and grown. Really, it's 2 procedures in one, so a little bit of rerouting here. We make that small pouch at the top, and then we reroute the small intestine. Now, lots of hormonal stuff here, and maybe Dr. Stroh can talk about what happens and why this is so darn good for diabetes. Even before people lose weight, there's hormonal changes. They leave the hospital, we just put them on a sliding scale or some other regimen, and they don't even use the sliding scale, just leaving the hospital. They haven't lost any weight yet. And anecdotal, I understand, but I mean, it happens regularly, and they come back and they say, I never had to take it since then. I say, congratulations, you don't have diabetes anymore, before you lose weight. So there's hormonal changes that we can have a whole lecture on why the bypass is a great procedure for specifically diabetes. And again, we talked about the overall complications, but as the benefit kind of goes up, the risk goes up with these procedures as well. Real quick on the SATI, it's called a million different names, so if you go to research it, just look at the picture and just try to decipher. Make sure you talk about the right procedure because it goes by 100 different names. The society has kind of decided on SATI, SADI as the name for this procedure. Basically consider it a sleeve gastrectomy with a gastric bypass on top of it. If there was a test question that said, what is the best procedure for diabetes today? This is the answer, the SADI. What is the best procedure for losing weight today? This is the procedure. But at what cost? I think we're still trying to figure that out. This is the one that you could get malnourishment with. This is the one people do get, increased like bowel movements with for sure. Is always a risk. Some people don't, some do. I'm still waiting a little longer before this becomes the one I do on a lot of people. This is only one I'll do once in a while. As you can see, it's only 2% of procedures done today. So enough of that. But let's talk about the estimated bariatric surgery numbers in the year from 2011 to 2019. And you can see how it has slowly gone up. Just 10 years ago, it's almost, like 1.5 times itself in those 10 years. And you can see the band started off in 2011 as 35% of all procedures performed, and then 8 years later, we're down to 1%. So that was really where the country moved away from the band. It doesn't work, people regaining weight, and then all the complications that come from it. And that's when the sleeve started really taking off. So you can look at the sleeve numbers there from 17% in 2011, and now it's up to 61%. In fact, now I would say it's even more. Side note, I do think we're over-sleeving people. Let me mention the one issue with reflux that you might be seeing with your patients, right? The sleeve gastrectomy does have a chance of inducing more heartburn and reflux with patients. So if it's not medically controlled, then they are a candidate to be converted to a gastric bypass. That happens rarely. I see a lot of them because that's where they come, right? But overall numbers, the reflux is kind of the sleeve's Achilles heel. So it's probably going to swing back a little more to the bypass. Again, you might see closer to 50-50, and that's kind of what our practice is when it comes to sleeve and bypass. And again, these other procedures, very rarely done. We just don't see great long-term. And what you see, let me go back. What you see too is the revision procedures going up more and more. Like I said, about 1/4 to 1/5 of my patients are all revisions, really going from a gastric band, and we convert them to a sleeve, or we convert them to a bypass, or like I mentioned, a sleeve, and then you convert them to a bypass in these rare cases. Many times a Nissen fundoplication, back in the day, someone would do a Nissen fundoplication for reflux on a BMI of 50. That we know that doesn't work. Those people need to be a lower BMI for Nissen fundoplication to work. The surgery for the obese patient with reflux is a gastric bypass, right? That is the answer. It's a gastric diverting procedure. So all that acid and bile is diverted way away from your esophagus, right? So it cures reflux, not to mention all the other benefits with the bypass. So how effective is bariatric surgery? Well, the expected weight loss of your excess body weight. So again, let's say you weigh 250 pounds and you're supposed to weigh 150 pounds, so you have 100 extra pounds on you. With diet and exercise, congratulations, you might weigh 245 pounds after a few years, and probably what's happened is you gained weight. The sleeve, on average, 55 to 65% of that excess body weight. So again, someone who's 250, you're going to get down to 195, 190 with the sleeve gastrectomy. And these are long-term answers, all right, long-term numbers here. The bypass, a little bit more with the 65 to 75%, and the single anastomosis duodenal switch, again, more, but at what cost? Keep asking yourself that. That's the one we got to think about. But here it is. Of all the slides, of all the presentations I've ever given, this is my all-time favorite. You can see, and sorry that it's kind of dark, didn't come out great, but type 2 diabetes after getting bariatric surgery, 45 to 68% resolves, folks. That's not going from injections to taking metformin. That's actually coming off all of your diabetes medications completely, right? I think there's a huge lifestyle benefit to going from injections and insulin and checking your blood sugars 5 times a day to just taking a pill and being controlled, right? And those aren't even included in those numbers. So we're talking 45 to 68% resolved. We're not on any diabetes medications, and we know this. You guys hopefully see sometimes in your practice how this happens. Mental health issues, sleep apnea, resolved 45 to 76%. They are off their machine. Again, that's not even taking into account when people take their settings on their machine down a few notches, which I think people benefit from that too. They like going down on their requirements, right? So profound effect on people's health And here's just to mention the Stampede trial from 2017 in the New England Journal of Medicine, specifically about diabetes. I'm waiting. They're going to do another. We're at 10 years now, so I'm actually kind of, and maybe it came out yesterday or something. If anyone knows, please tell me. We should have a 10-year follow-up on the Stampede trial any day now, I think, where the initial outcome was to getting your hemoglobin A1C less than 6, and you can compare this to medical therapy versus either the sleeve or the bypass with medical therapy, so combining it, surgery and medicine, and you can see the profound impacts. Really, the primary outcome. I wish I could point. Oh, okay, you can kind of point there. The primary, it's a three-pointer. I can't aim that. You can see that the primary outcome was met. Only 7% of people who had the medical therapy were had a lower hemoglobin A1C, while it was about 26% and 20% when you're talking about the surgeries. And that's, they all started at over 9. A lot of issues with this study. They used BMIs from 27 to 42, and our average BMI is at 42. So it's really a little bit off. Some issues with this study, but it's kind of one of those landmarks that people point to a lot. But it does confirm the superiority of surgery to medication alone. And here's a nice review of the 12 randomized clinical control trials between that specifically looked at type 2 diabetes with surgery versus medication. Again, I'm not sure if you're going to be able to get these slides, but you can see profound impact here. And you can see the band up here, right, even had some outcome, but those were very short term, 2 years and 1 year. We know those numbers fall off with the band after the 2-year mark. Weight recidivism, everyone's talking about how, what about that person who regains weight? And this is a difficult talk because I think I've read every single paper about weight recidivism, and every single one is different. They have different criteria for what failing to lose weight is. Don't get me started. Okay, so what they say is if you lose less than 50% of your excess body weight, so that's in our example, let's say you're 250 pounds, you should be 150. You initially lose, you get down to 180 pounds, right? That's 70% of your excess body weight. You're at 180 pounds, you lost your diabetes, you lost your blood pressure, you're doing awesome. 10 years down the road, okay, you're at 201 pounds, all right? You're 49 pounds less than where you started. You still don't have diabetes, you still don't have blood pressure, but you read these studies and they say that's a failure. They've regained weight. I beg to differ. The person just lived 10 years, 70 pounds less than what they've been. They're still 49 pounds of less than where they started. They are not on diabetes medication anymore. They're not on blood pressure. They lived a long, healthy life, and the life expectancy has gone up significantly because of this. So, taking all that into consideration and the way they have different ways of measuring failure to keep your weight off in all these different studies, you can kind of mush them all together into a meta-analysis. What was attempted here, it's pretty good. And the number I stick with is about 17.6% of people have weight regain after doing bariatric surgery in the long term. But again, what does that mean? More interesting in this paper, if you look at it, is what did they find? All these different things which have a positive correlation or a negative correlation with gaining weight. Again, this is, I think, the most important thing for me. The negative correlation, in other words, people who have a low postprandial GLP-1 was correlated with success in weight loss. But the ghrelin didn't. These could be artifacts in the meta-analysis. But interesting to kind of dive into these studies and see what is the cause. And really, it's behaviors, right? We know, we talk to patients a lot. This is not magic. None of this is, I'm not selling you anything. This is a tool you can use to help you lose weight. We know the benefits of it if you stick to what you got to do. But here's some things we can maybe help guide our patients to help how you should be living your life. Again, don't have sweet consumption, emotional eating, portion control, all that kind of thing. So let's talk nuts and bolts of how do we get people into surgery, right? We know that it's effective. We know it's safe. We know we have this epidemic going on. Well, who is the metabolic and bariatric surgery candidate? Well, in 1991, the National Institute of Health came out with a criteria saying, this is the people who are eligible for surgery, and guess what? We still use that today, right? They haven't evolved. with the caveat, about 6 months ago, there was a paper, there was an article that I think it was CMS in the state of Washington said people with a BMI of 30 to 35 with diabetes are candidates. That came out. I haven't seen insurance companies pick up on that yet. I haven't seen anyone with a BMI of 30 come into my office with diabetes to get surgery, not one, but we need to push that somehow. Starts with you guys. But we do know that and the 91 NIH criteria said BMI of 40 or above, congratulations, you are overweight enough, so to speak, that you qualify for surgery, okay? BMI of 35 with medical comorbidities. So that could be diabetes, blood pressure, sleep apnea, arthritis, you need a hip replaced. So 35 with medical comorbidities or BMI of 40, you don't need anything. And then a history of failed attempts at weight loss, which is documented by our people in this room. Thank you very much. So we know how effective it is. We know the number of people that have a BMI over 40 in this country or a BMI of 35 with diabetes or blood pressure. How many people would you guess who are eligible to receive this life-saving, life-prolonging, life-quality improving procedure actually get the surgery? Well, guys, we're looking at a big, solid 1%, okay? There is a massive under-referral. So this is where I get to yell at my primary care doctors, who I love. 1% of eligible bariatric surgery patients get surgery, right? I'm not saying we got to make that 50%. Just make that 2%, right? Because you're doubling the number of people that we help with this kind of procedure. And in terms of, and I'm using St. Francis as an example because that's the one that I work at, so I can't speak to every different hospital system and how many insurances they take, but I know there's a ton of questions about the insurance workup for people when you're in the primary care setting. In terms of our program, we accept them all, but the key is, and this is what you might run into, when insurance companies give you a hard time, you just have to make sure that there must be bariatric surgery benefits, right? There's always a thing in there. This plan does or does not cover any associated costs with weight loss surgery, right? So it's the benefit. You have to find the bariatric benefits. If they have benefits, I'm sure they qualify. We'll be able to get them qualified. And I said, we will check that for you if you send your patients over the mountain to us at St. Francis. But again, we basically take all insurances. Thank God. I was so happy we got that Medicaid contract several years ago, which we can help out all those people. So first, they have to have benefits, right? The first step for you guys, because everyone likes to know, what do? I have this person in front of me. They have a BMI of 50. They have diabetes. They're interested in bariatric surgery. Where do they go? You got to get them into the seminar, okay? And in fact, whether they have benefits or not, just send them to the seminar, right? I need a cowboy hat and a shirt. Send them to the seminar. That is where they can learn. We do them online, at least our facility, or I know Spokane has a nice program out here too. Send them to the seminar where they learn. It's free. It's purely informative, where they learn about the surgeries, some of the slides they'll see that I showed you today, and answer any questions about and just getting an introduction. All the insurance companies require that too. After that, then they get plugged into our system for the initial consultation, and then we'll see them in the office. We'll send them home with a checklist, and then they will go through all the different things. The time course for bariatric surgery, why does it take so many months to get surgery? Well, it's really the time factor is that nutrition element. Some programs require you to do one nutrition visit, others require you to do 6 or 7. The Medicaid ones, the government ones require you to do 12, 2 a month for 6 months. If you have 5 visits, you gotta do them every 30 days. So that's kind of this process that patients have to go through. In the meantime, as they're doing these nutrition visits, they can do the psych eval, which is still a hangover from the 90s, that everyone has to get a psychiatric evaluation to get bariatric surgery. My inguinal hernia patients don't need a psych eval. Pre-op labs, EKG, imaging studies, and medical evaluations as to make sure they're all optimized. But from the primary care doc's perspective, I think the biggest thing is get them to the seminar, and you can basically then step back, and then us or whoever you refer to can kind of take the patient down the journey, and then you kind of be helped along the way. You don't have to get them, you don't have to call them up and argue with insurance companies to get them cleared, right? Just get into the seminar where they can learn about it and see if that's an option that they want. Again, I don't want to operate on anyone unless they are 110% ready to do the surgery. So we have to kind of flush out a lot of things. So again, once they see us in the office, they go finish all their stuff, and then they get approved for the surgery. After, you cannot get approval for the surgery until you finish that big checklist and you do the stuff. So I think a lot of primary care docs get caught up in, I want them to get surgery, you start fighting with the insurance company. They won't listen to you, and they'll kind of drag it out because you got to finish all the nutrition stuff before you even think about submitting, right? So just save yourself, right? Finish everything, and then it gets sent to the insurance company, which all should be done by the bariatric surgery office, not you guys. And then they get approved, and then they do the rest of it. They get more education with nutrition courses, nursing courses, pre-op visits, the surgery day, first op appointments. What do we do with follow-up? We see patients 2 weeks, 6 months, and then every year after that. We want to keep on track with diet and exercise. Yearly labs. Again, who does yearly labs? People ask me all the time. Anybody. We can order them. You guys can order them. You know, they're nutritionists. I'd like them to follow up with a nutritionist long term as well. They can take care of that, and so forth. So real quick, I think I'm going to end here early here. The journey begins. You can't go back and change the beginning, but you can start where you are and change the ending. It's a message we like to kind of refer to our patients. Thank you very much, guys.